Welcome to Bench to Bedside, a weekly series of live conversations about recent advances in cancer, from the research bench to treatment at the patient's bedside. And now, your host and the director of the University of Kansas Cancer Center, Dr. Roy Jensen.
Good morning. I'm Dr. Shrikant Anand, and I'm sitting for Dr. Roy Jensen. Thanks for joining us for today's episode of Bench to Bedside. Today we have two amazing scientists. First one I'd like to introduce to you on my left is Dr. John Taylor. He's the Director of Basic Urology Research, and he's also the co-leader of the University of Kansas Cancer Center's Drug Discovery Program. And then we have Dr. Scott Weir. He is the Director of the Institute for Advancing Medical Innovations, a tongue twister, I should say, for the University of Kansas Medical Center. And he's also the Associate Director for the University of Kansas Cancer Center and really involved in drug discovery and translating it to the patients. So today we are focusing our discussion on the latest in bladder cancer research and treatment. And I want to also let you know that we have Alicia Miller, who is here in the studio, and she's waiting to get as many questions from the audience as possible so that we can give that to our two experts here who can answer those questions for you. So let me start with you, Dr. Taylor. John, tell me about bladder cancer. Tell us, what does it mean to say that somebody has bladder cancer?
Shri, I think you've heard me say in the past, bladder cancer is the black sheep of cancers. It's a very common disease that is under-recognized on the national and international front. It's the fifth most common solid tumor in the United States. About 80,000 cases are diagnosed each year. And it amazes me when patients come in with bladder cancer that they've not heard of it. It's not something they're aware of. But bladder is the organ that allows us to be socially acceptable and hold our urine until it's time to expel it. It's a very important organ, but we can't live without it.
So tell me, so 80,000 patients a year. How long do they live with this cancer when they do get it?
It all depends on the stage of presentation, so how advanced the cancer is when the patient presents. Fortunately, the majority of patients will present with early stage cancer. And the survival overall is very good. I think we're looking at 5-year survivals for all stages of cancer. So from the earliest to the most advanced, we're looking at anywhere from 70 to 90% 5-year survival rates.
So that's a long survival. And some of these patients live for 30, 40 years then?
Very long time. So
wow.
For patients with the earlier stage cancers, they can live 30, 40 years, but they're at risk for high rates of recurrence of the disease.
That's right.
And that's what makes it one of the most expensive cancers to treat.
You came up with the most important second question. What are the risk factors that puts you at a high risk for bladder cancer?
Smoking, 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 and then exposure. So we call it a disease of exposure. There are no known genetic risk factors for it. There are some in question, but by most parts, it's considered a disease of exposure. Smoking is the #1 risk factor. About 60+% of all cancers are directly causally related to smoking. Then we look at environmental and occupational exposure to other carcinogens, and there's a whole laundry list of them that are out there. Interestingly, the Department of Defense has recently recognized that soldiers exposed to defoliants in Vietnam, so typical Agent Orange, Agent Blue, may be at increased risk to bladder cancer due to some of the chemicals that were found in those defoliants.
So that brings up an important question. So all these veterans who have potentially been exposed to these things, is the VA doing something about ensuring that they're not, are they being monitored? So how does bladder cancer get detected, and how do you currently treat them?
So let me back up to your first question, which is the DoD. We were very excited several years ago when the initiative was brought forth, because those of us in the field felt that we were not getting a fair shake at some of the research money that was out there. The DoD opened up their major research program.
Let me start. Yeah. DoD is Department of Defense.
Sure. So the Department of Defense opened up their research program to bladder cancer about 3 or 4 years ago, and it's been wonderful to have access to some of those funds. So they have recognized that they are beginning to make inroads into supporting research, which is critical to advancing care for patients in this field. Your second question regarding detection, bladder cancer is unique amongst cancers in that it's not typically detected at autopsy, so it's not something that's incidentally found when people pass. It's almost always found during the patient's lifetime, and it's found about 80% of the time with visible blood or microscopic blood in the urine. And then importantly, about 20% of the time, patients can present with new onset of urinary symptoms, urgency, frequency, discomfort in the pelvis. And we have to be attuned to that. And because of that, and because of the similarities to other symptoms that people will experience as they age, many patients experience a delay in diagnosis, particularly women, due to coincident findings such that would be present in urinary tract infections or just urgency frequency of urination with aging.
And do they have burning sensation or anything like that?
Not typically. So the other common symptoms of a urinary tract infection are absent. And that's what makes
That's how you differentiate this.
So we call it painless blood in the urine, so not associated with other symptoms.
Okay, thank you. So if you're just joining us, we are here with Dr. Scott Weir and Dr. John Taylor, and we are talking about the latest in bladder cancer research. Remember, Alicia Miller is here in the studio to take your questions, and we are waiting to get your questions. Please also share this link with people you might think have the benefit with our discussion. Maybe they can join in and then ask questions. And please definitely use the hashtag #BenchToBedside. Let me turn my question to you, Dr. Weir. In your role as the KU Cancer Center in advancing drugs, your focus on the bench to bedside. Can you tell us a little bit about the drug that you have discovered for bladder cancer?
Sure, Shri. And by the way, the drug discovered was discovered by a team here at the University of Kansas Cancer Center, of which you are both a part. Ciclopirox prodrug is a promising treatment discovered in our laboratories for the treatment of non-muscle invasive and muscle invasive bladder cancer. It represents the first KU invented cancer drug that we've advanced from the bench to the bedside.
So let me just turn back to you. What kind of drugs are used for the early stages of bladder cancer? Is there one?
So I've got to throw in a little bit more into your answer because there are, I think, some important things to understand about bladder cancer, which are concerning to those of us in the field, but also we're in an exciting time. So bladder cancer, whether it's in early stages or late stages, has not seen a novel or new treatment in decades. So
wow.
For non-invasive, so for early stage cancers that are not invading the wall of the bladder, we're using immunotherapeutic called BCG, which is placed into the bladder to incite an immune response, and that's been around since the 70s. For more advanced bladder cancer, where we actually have to remove the bladder, we're doing what's called a cystectomy, which is removing the bladder. It's one of the biggest operations that we can do, and it's got high risk of complications. Now, I should say that my grandmother had a cystectomy in 1960, and I like to give introductions when I give presentations outside the university that my grandmother would roll over in her grave knowing that her grandson is doing the same operation 60 years later, almost 60 years later from when she had her operation. So we haven't made a lot of inroads in it. That's one problem. We're beginning to see a lot of inroads into this area in today's world, and Ciclopirox is an example of that.
So it sounds to me like Ciclopirox is a really awesome new development that has happened in the recent past.
Absolutely. If we can introduce any novel agent that can act in or have better results than we typically see with other drugs or other treatments, or if we can have a new agent that could be administered differently. So for people that have bladder cancer that's in early stages, they have to come into the office once a week for 6 weeks, and then every 3 weeks at various time points to have a catheter put in and have an agent put in their bladder, and then have to hold that. So if we could find a novel agent that's not administered in that way, either intravenously or orally or some other route, that would be earth-shattering to the field.
So you mean that I could, if I had bladder cancer, I could be at home and just take a pill or have a nurse come and just give me an injection like a diabetic patient does.
Right. For some
Potentially.
for some of the agents that are being developed,
That'd be awesome.
including Ciclopirox, it would be revolutionary to the field.
Yeah. So where are we with this drug?
So the work that we completed within the university was we demonstrated that Ciclopirox prodrug kills bladder cancer cells in the test tube. We also showed that it is effective in treating bladder cancer in mice. And then we also were able to figure out how to manufacture the drug and formulate it into an injectable drug product, much like, as you said, Shri, a diabetic would inject insulin. And then with that, we partnered with a biotech company here in Kansas City called Cyclamed. And together, we completed the studies required by the Food and Drug Administration,
FDA,
to be able to advance this drug from our laboratories to patients. We completed that work, received clearance from the FDA in the fall of last year, and we're currently evaluating the safety of Ciclopirox prodrug in cancer patients at 4 sites across the U.S.
Wow.
So, Shri, I got to interject and say one other thing about Ciclopirox, or a drug that would be administered that would get into the circulation and be cleared in the urine. So one of the interesting things or novel things about Ciclopirox is that it winds up in the urine in high concentrations. And as I talked about treating bladder cancer, putting a catheter into the bladder and treating the bladder, you can get the same types of tumors in the lining of the kidneys and the tubes between the kidneys and the bladder, the ureters, on down. Those are far more difficult to treat because of gaining access to them. So if we had a compound or a drug that was...
So let me just stop you there for a split second. What you're saying is now we give them BCG, where you take a catheter and you put it into the bladder.
Yeah.
But the BCG cannot quite make it up to the tube that connects between the kidney and the bladder. And so this cancer can also be in that spot. And if that happens, then all bets are off. The BCG never makes it there.
Exactly. There are ways to get the BCG into the upper tracts, is what we call them, between the kidney and the bladder. But it's a little bit more complicated, it's a little bit more difficult, and the efficacy is not.
And the patient suffers through all of this.
And the patient has to deal with all of this. So it's something that could treat the upper tracts, the kidney lining and the tube lining between the kidney and the bladder, as well as treat the bladder, again,
without making
without having to put catheters or anything
and
else like that would be dramatic.
And what is the recurrence rate for patients who get BCG?
So we still look at recurrence rates for the early stage diseases. We look at 5-year recurrence rates can be as anywhere from 40 to 70%, depending on the
40 to 70%. That means pretty much almost 1 in 2 patients are in the doctor's office because they have a recurrence.
Exactly, and that's why we go back to being one of the most expensive cancers to treat over the lifetime of the patient, is due to the need for surveillance, additional multiple treatments for recurrences, and if the tumor progresses, if it advances into an advanced stage, then they are subject to the major operations that we talked about.
So then Medicare is going to be really happy if a drug like this comes out.
Patients will be really happy if a drug
Patients
like
will be
this
happy,
come out. Yeah,
but so
absolutely.
will the medical organizations that are subsidizing this.
And so if I can add, based on how we believe this drug works to kill bladder cancer cells, our vision for this drug is it would be given in combination with standard of care therapy to reduce the recurrence of bladder cancer in patients who are at high risk.
So that you can reduce the side effects of the drugs? In addition to the fact that you can treat the ones in the upper tract, what are the side effects of BCG? Is that really morbid for the patient?
No, BCG is not so morbid. It's most of the symptoms patient experience from that are what we call local symptoms or irritative symptoms: increased urgency of urination, burning with urination, possibly some blood in the urine. So the treatments are not horrible, but if you talk to patients that have them,
I wouldn't want it.
Absolutely, yeah. So if you gave a patient a choice of having a catheter and something like BCG put in the bladder versus taking a pill, having something infused in the vein, or some other form, I guarantee you they'd all line up for the latter.
Yeah. Congratulations, guys. This is really a major achievement. Yep. When do you think this would get to the patients?
Well, we're evaluating the safety of this drug in cancer patients currently, and our plans are to expand this clinical trial to begin evaluating its activity in bladder cancer patients next year.
Oh, great. Okay, in case you're just joining us, we're talking about bladder cancer, and Alicia Miller is here to take your questions, which she can then ask us, and the experts here can tell you the answers to that. Alicia, do we have a question?
Yes, we do. The first question is, where are you in the process of making Ciclopirox available to patients?
We just talked about that. Scott, do you want to answer that again so they can hear it?
Sure. We're currently evaluating the safety of Ciclopirox prodrug in cancer patients who are participating in a first-in-human trial that's being conducted at 4 clinic sites across the U.S. And then our plans are to expand this trial next year to begin evaluating it in bladder cancer patients.
So when you get this done, you go back to the FDA, you show them the data, and then they say go, no go to the next step.
Correct. The process is we will collect all the safety data from the ongoing clinical trial. We will then meet with the Food and Drug Administration and work with them to then design subsequent clinical trials to look and to measure the activity, the efficacy, and the safety of this drug in bladder cancer patients.
And the goal is to have that open here at KU.
And I was going to ask you, so at that point, our patients in KU, in the hospital here, in the University of Kansas Cancer Center, they will have an opportunity to also participate if they are eligible for the trial.
Yeah, and exactly, Shri. And really, that's the vision for our cancer center. The vision of our cancer center is to transform bedside and bench discoveries into promising new treatments for cancer, diagnostic tests for cancer, to be able to bring that research to our patients.
Yeah, thank you. As we approach the end of today's Bench to Bedside session, Dr. Taylor, Dr. Weir, any final takeaways?
Well, I guess if I could just say, the effort required to discover and develop a new treatment really requires a team. We like to say it takes a village,
yeah.
And that's the approach we take here to discovering and developing new treatments. And it not only takes a village of researchers within our university, but also partners in our region and certainly the private sector. And what we've built here is an innovative approach to partnering with the private sector to be able to bring these promising treatments forward to patients.
So when you say private sector, you're talking about research organizations in the private sector, as well as investors and
exactly, yeah.
Everybody.
All of the above. All of the above, and that would include again working with the Food and Drug Administration to be able to bring these treatments to patients.
John?
Yeah, I think that from a patient perspective and from a provider perspective, it's been very frustrating in the past 20 plus years of practice that we haven't had something new for patients. 10 years ago, the field of novel drugs or treatments for bladder cancer was an arid desert. And for my patients and all those who are afflicted with this disease and their care providers as well, it's a very exciting time because we're finally beginning to see a wave of novel agents on the horizon. And I think that we here at KU are very well situated in the middle of that wave. It's a very exciting time. They can't come fast enough for our patients. These novel agents cannot come fast enough. And I think that we're on the verge of seeing a whole host of them explode.
So one final point, I was wondering, we are talking about therapy, but this could also potentially be a preventive. So once we've given them as a therapeutic, we might potentially be able to move it to like an aspirin. This could potentially be a therapeutic, yeah. I mean, a prevention agent, so that the patients may not have a recurrence, which is the biggest problem right now.
And that's one of the biggest issues with bladder cancer, is not only treating the initial tumor, but patients are at risk for recurrence for the rest of their lives. Yeah. So we need something that can handle the current disease as it presents, and then reduce their risks of recurrence, and by doing so, reduce the risk of progression throughout the rest of their life.
Alicia, she's here in the studio taking questions. Any final questions, Alicia?
There are no more questions at this time, but if you have any more questions or comments, please submit them and we will monitor throughout the day.
Thank you, Dr. Taylor, Dr. Weir. This has been for being here today with us and telling us about the latest and greatest at the University of Kansas Cancer Center in relation to bladder cancer. Please do visit the kucancercenter.org website. We appreciate all of you joining us. Please let your friends know, your colleagues know, your family know. They can go into our Facebook site and they can find this video. It will be up there. Thanks for watching.